Hi, my name's Nancy Poole, and I'm the director of the Center of Excellence for Women's Health and the prevention lead for the CanFASD Research Network in Canada. And this is to introduce you to a series of presentations about research on FASD prevention. So this series shares brief explanations of what we know about FASD prevention from those who are currently conducting research from a number of countries. And the goal is really to make this research accessible and to inspire people to take up the findings in both practice and policy. So you can see we have 5 sections in this series, starting with presentations about stigma as a central issue in preventing FASD, then offering some frameworks for FASD prevention, then looking at what we call level 1 prevention in Canada, which includes broad awareness raising, health literacy, and community-led health promotion efforts. Then looking at what we call level 2 prevention in Canada, which is brief alcohol interventions plus integrated support and referral as needed with all women. And finally, levels 3 and 4 prevention, which is about engaging and assisting pregnant women who use alcohol or are trying not to, and who face related health and social concerns. It also involves supporting new mothers and their children to build on the gains they've made to reduce or stop drinking in pregnancy, to support them to improve their health and their social status, to support attachment and promote assessment of children's health. So the next section of presentations are about brief alcohol interventions and really, honing in on discussions about alcohol by health and social care providers with girls and women and their support networks and how critical that is to FASD prevention. These conversations we see as doorways to change and to supportive services that may be needed by women and girls. So here we hear about how the study of brief intervention can be foundational to putting in place a broad scope of community-based interventions. We hear about an adaptation of project choices, which is a preconception intervention that has significant evidence for effectiveness in a range of contexts. And then also about the views of women that are captured in some qualitative research and how their views can inform brief interventions.
Greetings from San Diego. My name is Annika Montag, and I would like to share some of the FASD prevention work that we've been privileged to participate in over the last decade in an Indigenous community. We've conducted primary, secondary, and tertiary FASD prevention research in a sequence led by the community. Indigenous communities differ, and respecting these differences is key to effective research. I'll present a few of our research projects and lessons learned, and our Healthy Native Nation Family Support Project team will elaborate on the specifics of our work in a separate talk. And I have nothing to disclose. So the first step is to be invited in. FASD prevention had been prioritized by the tribal board of our community, and this was a crucial start. From the beginning, each of our projects was approved by the tribal IRB as well as 1 or 2 local university IRBs. And we obtained a certificate of confidentiality from the NIH whenever that was relevant. Forming a community advisory board is an essential first step. They advise us and keep us on track. Similarly, consulting cultural experts has been vital in our reservation-based work. We hired, trained, and listened to local Native community members. Staff determined how, when, and where recruitment would take place, and how we interacted with the community. This avoided culturally inappropriate mishaps. And we sought community buy-in with strategic partnerships. In our first FASD prevention study, we tested the efficacy of a culturally modified screening, brief intervention, and referral to treatment, or SBIRT intervention. It was to reduce risky drinking and vulnerability to alcohol-exposed pregnancy. We used an RCT study design, initially recruited 263 women between the ages of 18 and 45, of whom 16 or 6.1% were lost to follow-up. Our baseline questionnaire included questions about alcohol consumption and contraceptive use. Following baseline evaluation, women were randomized into web-based intervention or assessment alone. And assessment alone also included provision of written information in the form of brochures. And they were followed up at 1, 3, and 6 months by phone. And we learned that half of participants reported not currently drinking any alcohol, but current drinkers tended to do so in a heavy episodic manner. 1/4 reported using no contraception. We found that about 1/3 of participants were at risk for having an alcohol-exposed pregnancy. So women in both arms of the study decreased drinking drastically, even those in the assessment group alone. Our results made clear to us and to the community that the community was at risk for FASD. And also that meaningful assessment, having women really think about how much they consume and what that means, may decrease consumption among some women. And which women, you may ask, and we asked this as well. We found that a disturbingly high proportion of our participants tested positive using the PHQ-9 for depression, more than 1/3, 36%. We investigated the impact of depression further. We examined depression as a predictor of vulnerability to having an alcohol-exposed pregnancy, and we explored whether depressed women responded differently to our SBIRT intervention. We found that in our study, depressed women, but not non-depressed women, reduced drinking in response to our SBIRT above the reduction with assessment alone. So screening for depression can be a way to not only identify women at higher risk for having an alcohol-exposed pregnancy, but it can also serve as a resource allocation tool. A clinic may want to refer women testing positive for depression to more intensive prevention measures. And treating depression in women of childbearing age may reduce alcohol-exposed pregnancies. So this first study made us wonder what kind of support was available to families affected by alcohol-exposed pregnancies. And therefore, at the suggestion of a local Native research assistant, we applied for funding to explore what type of support was available in the community and the needs and priorities of families with family members with FASD. Through our resource survey, we realized that there was limited support and none specific to FASD. And in response to identified needs, we established the first Native no-FAS affiliate, Healthy Native Nation. In investigating the needs and priorities of those affected, we ran into some difficulties. We had trouble locating people who were aware of their status. No diagnosis had been available in the community. So we brought in a way for people to access diagnosis. In a stroke of luck, the NIAAA funded COFASP study had recently been completed nearby. And we were fortunate to obtain funding and access to required expertise for a prevalence study by linking to the COFASP study. We used culturally congruent methods in a cross-sectional design and active case ascertainment. Local staff were responsible for recruitment, for all communication and scheduling, for all maternal and child-related interviewing, and one staff member was trained to do neurobehavioral exams. Of 488 eligible children, 119 diets were consented and 113 assessments were sufficiently complete to reach case conference. No children were diagnosed with FAS. Our total FASD prevalence was estimated at 4.1%, and this is not different from the national COFASP sample prevalence. It falls within that conservative estimate of 1.1 to 5%. So this study provided an opportunity to raise awareness of FASD. It identified families affected by FASD and linked them to needed services, and it increased capacity of the local clinic and of the community. And also, the reason we initiated this, it allowed us to go back to study number 2, Healthy Native Nation, and determine the needs and priorities of families dealing with FASD on the reservations. Our findings will be presented in a different talk with Rhonda Romero and Shantine Armayo titled FASD Prevention in a Reservation-Based Indigenous Community. So communities differ. There are shared risk and protective factors, and there are shared community structures and historical experiences. But to be effective, it's important that the intervention be culturally congruent. We conducted community focus groups and interviews to inform our modification efforts of this SBIRT that I spoke about earlier. Some of the modifications are outlined in the slide and go deeper than the more surface changes we made in the earlier version. Our delivery method was changed from web-based to in-person, motivational interviewing-based. New materials were created, some assessment sections were cut and others were added. And by dual purpose questions, here we mean, for example, you say, in situations where you feel pressured to drink, how do you avoid drinking? And then you would have examples serving as suggestions listed as answers to check off. We recruited 343 women in total, of whom 33 were pregnant. And noteworthy risk and protective factors in our community with relevance to prevention included the perception that peers consume more alcohol than you do, which indicates that a risk of alcohol-exposed pregnancy may be reduced by a cultural norms campaign, and that women's drinking is highly influenced by female friends and relatives, indicating the potential of using a kind of girl power intervention. So women, and 39.5% of them, felt pressured to drink at some time. When and why are community specific, and these serve as potential targets for prevention. In terms of tertiary prevention, we've initiated an additional grant-funded study that's creating and testing a culturally congruent intervention that includes individuals, families, and the community, because children with FASD do not exist in a vacuum. More about this program is also presented in that other talk titled FASD Prevention in a Reservation-Based Indigenous Community. We also continue our Healthy Native Nation mission to increase awareness of FASD, provide advocacy and support for families, and improve and strengthen the lives of those living with FASD. During our progression through this series of FASD research studies, the most important lesson that we've learned is that it's all about respect. Trust community wisdom and build on community strengths. We acknowledge our funders and the community members, the community advisory board members, and cultural experts who altruistically share their knowledge and enthusiasm, and the families and individuals with FASD who inspire and motivate us. Thank you very much. And please contact us if you're interested in any of our publications or would like to know about our work, or talk to us. Thank you.
Hey everyone, my name is Jessica Hanson. I'm an assistant professor at the University of Minnesota Duluth, and I am here to chat a little bit about the Choices Intervention. So the Choices Intervention is a well-known intervention that really focuses on prevention of alcohol-exposed pregnancy during the preconceptual period. And so it really addresses this idea that a lot of alcohol-exposed pregnancies happen early on, particularly in the first trimester. So trying to address this idea that a lot of pregnancies are unplanned, and if a pregnancy is unplanned, typically a person will continue with their current behaviors, and that includes drinking alcohol. And so the goal of interventions like Choices is to both reduce risk for unintended pregnancy, and also for those who are planning pregnancy or are at risk for an unintended pregnancy, to reduce their risky drinking. And so this gets at that idea that alcohol-exposed pregnancy can occur, and oftentimes should occur, during the preconceptual period. And so Choices is one of a few interventions that focus on this time period, that focus on before a person even becomes pregnant. So Choices, the original acronym of Choices, stands for Changing High-Risk Alcohol Use and Increasing Contraceptive Effectiveness Study. This was a study that occurred from the late 1990s to the early 2000s, and it was funded by the Centers for Disease Control and Prevention in the United States. The original Choices study included individuals from 3 states in the US: Florida, Texas, and Virginia. And it enrolled women from a variety of sites. These included OB-GYN sites, it included people in recovery programs, and other more general community sites. And so it attempted to get at a more general population from these 3 states. It was a large sample, and it was a randomized controlled trial. The choices intervention uses motivational interviewing, and it's also based on the trans-theoretical model, or the stages of change. And so the activities embedded within the choices intervention use motivational interviewing, or MI, and these concepts from the stages of change to move people along in their readiness to both reduce alcohol use, reduce risky drinking in particular, and also increase their use of contraceptives every time they have sexual intercourse. Ultimately, the goal with changing these 2 behaviors is to reduce someone's risk for alcohol-exposed pregnancy. And so again, this was a randomized controlled trial. One group received this choices intervention, and the control group received basic information. And what the project choices intervention showed with this large sample is that the intervention worked and was very successful in reducing risk. There were significant changes in behaviors in order to reduce risk for alcohol-exposed pregnancy. So this choices intervention was seen as a success. It was seen as evidence-based. And ultimately, the funders and the people who started choices wanted to see this disseminated broadly. So what I'm going to walk you through is choices within an American Indian community, or several actually American Indian communities. These are just sort of these are examples that can be used for other studies if you are interested in replicating the choices intervention. Now, the curriculum from choices is you can get free through the CDC website. And so what I'm going to walk you through are potential adaptations and implementation questions that may come up. And so my past work and my current work involves this choices intervention with Indigenous tribal communities in the United States. And I use this framework to really outline the past and current work that I've done. And there are different phases included in both adapting, preliminary testing, and then ultimately conducting efficacy trials. So I'll walk you through those here. So in the first phase, there are parts of choices that can be adapted for different communities. And so we did a lot of formative work, such as focus groups, key informant interviews, community meetings, to run through the original choices intervention and what would need to be adapted for a tribal community. And so some of the suggestions are listed here. They include culturally appropriate images, different types of colors to make it a little bit more visually appealing, making sure that the materials are readable. So this would include the information given to our participants on fetal alcohol syndrome, on drinking, on contraceptives, to make sure that they understood the information given to them and that we addressed health literacy concerns. We also really needed to focus on common types of alcohol consumed. And so because there's such a large focus in choices on establishing drink size and understanding more about a person's current and past drinking, we need to really understand communities, not just how much they're drinking, but what they're drinking and how they consume that alcohol. And so typical alcohol consumption, like drinking a beer, a glass of wine, or a glass of hard liquor, is not as common in some communities. And so we needed to better understand what people are drinking and then how they're consuming that alcohol, if it's in a group, if it's in a shared setting. We also needed to understand types of birth control that are available. We work a lot with rural and reservation-based communities, and we needed to know what birth control is available within these communities, what contraceptives can people get access to, and what are they actually using in order to really make the choices intervention specific to this community. And so anyone doing work with rural communities, Indigenous communities, or really any community needs to understand drinking patterns, drinking styles, but also contraceptive use and what types people are typically using. And so this really frames the risk for alcohol-exposed pregnancy very locally. And these are changes that do not and should not change the validity of this particular intervention. We also conducted a validity study to dive a little bit more into the health literacy of the information we are providing to people and the intervention itself. And so we got input from the community, additional input from the community. We worked with content experts, people who worked with tribal communities, but also people who had a strong history of the choices intervention. We did think alouds with women of childbearing age. And we wanted to see if we made modifications to any of the instruments, any of the questionnaires, the activities, how does that impact really the results? And we did this through a test retest, where we had one group of people complete the original choices instruments, and we had another group complete the modified choices instruments. What this really showed us is that the original choices instruments worked pretty well, worked actually very well with our population. And so a study like this just validates that the choices intervention can be used across a variety of community groups, different subpopulations of individuals who may be at risk for alcohol-exposed pregnancy. So those are two major formative studies that we conducted. We then did a feasibility study. And so we enrolled 193 individuals who were at risk for alcohol-exposed pregnancy, and we enrolled them in the choices intervention. Now, the original choices intervention was 4 sessions, and we had 2 sites that did the intervention in 4 sessions, and we had 1 site that did it in 2 sessions. And we found later on there were no significant differences. So the choices intervention is typically done in person, and there's a curriculum that's involved, again, that is free on the CDC website, but note that it can be done in 2 sessions or 4 sessions, and it doesn't impact the outcomes. We saw a significant decrease in our participants in their AEP risk from baseline to the 2 different follow-ups. And so we saw this feasibility study as a success. We saw that this showed great promise in reducing alcohol-exposed pregnancy risk in this particular population. And so ultimately, we felt this was positive, it was beneficial, and needed additional research. And so currently we're doing a efficacy trial, a randomized controlled trial in an Indigenous community where we have a group, and this is similar to the original choices study, where we have a group who receives the choices intervention as we have adapted it, and then we have a group that receives just standard care. And so that's currently being supported and is currently underway in terms of data collection. And so the results are still pending, but we're hopeful that the efficacy trial further shows that this particular intervention can reduce risk for alcohol-exposed pregnancy in the population and ultimately could be disseminated more broadly. There are additional research needs. When we consider choices and we consider this idea of preconceptual reduction of risk for alcohol-exposed pregnancy, there's some different things that could be approached. One is to link prevention to FASD surveillance. And so a lot of our efforts are focused on certain subpopulations of people. My work with the choices intervention with Indigenous communities is really successful because of the collaboration we have with tribal communities. This doesn't necessarily mean that it's only tribal communities that need this type of work. And so linking prevention efforts to what's happening with surveillance would be essential, kind of a natural next step. Another natural next step has really occurred because of the pandemic that we've been facing the last 2 years, where we've had to adjust. We've had to create hybrid approaches to some of our prevention efforts. And so I think there's great promise in including technology, such as ecological momentary assessments, in our intervention work. Having more specific alcohol data when we're looking at prevention, having more specific data on contraceptive use and sexual activity as we address that with our participants would be very important. And so there's a lot of promise in that. And the final part is having more of an effectiveness research trial or a dissemination and implementation trial, depending on the results of our phase 3 trial. And so there's a lot of promise with choices, but also a lot of unanswered questions that can be approached in different ways. And so I thank you for your time. I'm happy to answer questions about choices. I really do think it's a great intervention, and shows a lot of promise for different populations.
Hi everyone, my name is Lindsay Wolfson. Today I'm joining from Canada on the traditional territory of the Anishinaabe, Mississaugas of the Credit First Nation, Mississauga, and Wendake New-Winsento peoples. And I am pleased to be joined here by my collaborator in this work, Vivian Lyall.
Hi everyone, I'm joining you from Australia, where I live and work on Jinnaburra Nation country. And yeah, I'll hand it back to you, Lindsay.
So today we're here to talk to you about our recent systematic review conducted by researchers in both Canada and Australia that explores factors associated with women's alcohol use reduction and abstinence during pregnancy. And in addition to acknowledging the land, before we continue, we also wanted to acknowledge our co-authors in this work, Dr. Natasha Reed, Dr. Nancy Poole, Dr. Karen Moritz, Sonia Egar, Dr. Annette Brown, and Dr. Deborah Askew. So globally, an estimated 10% of women consume alcohol during pregnancy. Alcohol use can really be influenced by a range of factors, including the normalization of alcohol in daily life, peer influences and social pressures, limited provision of alcohol use information and risk factors provided by healthcare providers or peers, confusion of what's safe, and also other structural considerations such as poverty, histories of trauma and violence, and barriers to accessing services. And to understand the small but growing body of qualitative research that explores women's perspectives and privileges their voices, we wanted to conduct a systematic review of qualitative research that explored the context, conditions, and factors influencing women's alcohol use during pregnancy.
So to conduct the review, we searched several databases and considered papers for inclusion that had a sample of pregnant or recently postpartum women, a specific focus on alcohol use reduction or abstinence during pregnancy, and studies that use a qualitative design and analysis methods. And we followed 4 stages of qualitative synthesis. So first, conducting the search. Second, assessing the quality of the studies. Third, extracting relevant data. And fourth, conducting the thematic synthesis. And for the final stage, we felt it was really important to adopt an analytical framework that could enable us to bridge the gap between an individual behaviouralist lens and broader considerations of the social and structural determinants of women's alcohol use. And for this, we found that the stigma action framework was well suited for this purpose. It's a framework that was released by the Canadian Chief Public Health Officer as part of the 2019 report titled Addressing Stigma Towards a More Inclusive Health System. So for the, here we have a table, a chart of the stigma action framework, and it really conceptualizes stigma and how it operates at the individual, interpersonal, institutional, and population levels. And there's many important examples that are highlighted in this table that I won't read over at this time, but it is important to note that these levels are interconnected, and when applied, they enable a contextualized understanding of women's alcohol use during pregnancy. And we also found that the framework was important for enabling us to identify gaps in the literature, limiting comprehensive understandings of factors influencing women's alcohol use, as well as factors that may support reduction or abstinence. So looking to our results, the review included 27 articles that were published between 1990 and 2020, representing 557 participants, ranging ages from 13 to 45 years old. While the majority of studies did adopt an individual behaviouralist approach to understanding women's alcohol use in pregnancy, again, the stigma action framework really enabled us to gain more contextualized understandings. And it was from those understandings that we identified 5 main themes. So first, social relationships and norms. Second, the role of stigma. Third, trauma and other stresses. Fourth, alcohol information and messaging. And fifth, access to trusted, equitable care and essential resources.
So for the first theme, social relationships and norms, at the interpersonal level, women across most studies highlighted the integral role of alcohol to their social identity and relationships, with many describing the pressures they experience from their peers, families, and partners to continue to drink during pregnancy. As one woman immersed in a heavy drinking environment shared, "I'm a major outcast because I don't drink, I don't smoke, I don't do drugs. When my grandparents have birthdays and stuff, they don't invite me. They think I'm high class. Any person who is pregnant, they become the designated driver. You become an adult babysitter." Women also shared how experiences of social pressure to drink were most pronounced in early pregnancy, when they were yet to reveal their pregnancy to their peers and their key support. As one woman stated, "It's tough when the pregnancy is secret. There really is a social pressure regarding alcohol. It's crazy." A significant factor implicating women's use, reduction, or abstinence from alcohol was the presence of support, or the lack of it, in their relationships. And here the role or absence of partner support was particularly influential for women across several studies. And at a population level, commonly held knowledge norms favouring low to moderate alcohol use in pregnancy were found to shape women's social environments, which were also influenced by a pervasive lack of awareness of prenatal alcohol exposure risk and of fetal alcohol spectrum disorder. So for the second theme, stigma, at the interpersonal level and across several studies, discriminatory views about women who consume alcohol during pregnancy were most commonly held by women themselves, and with many seeking to distance themselves from what they perceived as bad mothering. As one woman stated, "If they drink, they don't deserve to have a baby. I'm sorry, but they don't, because they're not thinking of the baby, they're thinking of themselves." For some, fear of judgment from peers, family, or healthcare practitioners was a key motivator for them to abstain from alcohol during pregnancy, while for others, it perpetuated social isolation and shame for them and caused their alcohol use to become hidden.
Unlike the first two themes, these final three themes, trauma and other stressors, alcohol information and messaging, and access to trusted, equitable care and essential resources, really highlighted how institutional and most frequently population level approaches were negated from the literature. One study related to trauma and other stressors explored how addiction, lack of access to essential resources, including healthy food, housing, income, unstable or violent relationships, and a lack of social support can really result in challenges to substance use reduction, and how trauma, including trauma associated with healthcare practitioners and experiences with healthcare practitioners, can create barriers to women's care. However, we know from our previous research how interconnected trauma and substance use are. For instance, this diagram, which we've included on this slide, where we were researching substance use, intimate partner violence, in the COVID-19 pandemic, really saw trauma as an overlapping and embedded concern within substance use, mental health, and violence. Women reported receiving a mixture of advice on alcohol use in pregnancy and limited provision of brief interventions and support. And this was most prominent in the theme that we saw in alcohol information and messaging. Some women reported that their healthcare practitioner endorsed alcohol use, and there really seemed to be a lack of consensus over low levels of use. Conflicting advice from women's social networks increased confusion and in some cases affirmed women's choices to continue drinking. Where alcohol messaging was framed as abstinence only, which was also widely reported, women felt as though the advice was unconvincing, controlling, and exaggerated, and that women's lived realities weren't reflected in the advice. None of the studies that were included considered the role of harm reduction, trauma-informed, or non-stigmatizing messaging. However, there was some mention made by women that being adequately informed about alcohol use risks and abstinence guidelines could facilitate reduction or abstinence. And regardless of messages, women who were directly or indirectly knew somebody with FASD were more accepting of abstinence guidelines. Our final theme on access to trusted, equitable care and essential resources was the one where we actually saw the least amount of evidence. And despite the importance of women accessing prenatal care, there really seemed to be a limited focus on the ways in which care could be accessed and could be equitable. However, one participant from a 2019 study described the importance of women receiving quality prenatal care that is tailored to women's unique needs. In this theme in particular, there was no reporting on institutional or population level factors, despite research and responsive interventions that act as remedies to the challenges that are cited by pregnant women, but also that really focus on service and system level changes, so that way individual level change can become possible. As we wrap up, we really want to think through what the implications of this work look like. The results highlight how, despite the literature's focus on individualist behavior and choice in prenatal alcohol use, the barriers and facilitators to women's alcohol use were rarely a result of individual choice, but rather a reflection of interpersonal, institutional, and population level factors. The results also highlight key gaps in literature where themes were or underexplored, including how harm reduction policy and practice, alcohol use messaging, and their role of safe, trusted, and accessible services in supporting women during pregnancy were available through pregnancy and the postpartum periods. And so as we wrap up, we wanted to link some of the work that's being done in Canada and Australia to address these gaps. On this slide, we have a handout that really links up some of the work on brief interventions. And these are collaborative conversations around alcohol and other substance use and related health concerns. They can be conducted by a wide range of health and social service providers, including physicians, nurses, midwives, sexual health service providers, anti-violence workers, elders, and Indigenous health workers, and others. And they can include a range of topics, including mental wellness, healthy relationship dynamics, health promotion strategies, and self-care. And while we've seen in the research that there has been some trepidation, particularly from physicians and healthcare providers, to discuss substance use with women out of concerns of being perceived as judgmental and stigmatizing, discussing substance use and how it's connected to other health and social concerns can really support women increase their health and well-being, regardless of their social and structural contexts. And so these were 6 categories that we came up with with my colleagues at the Center of Excellence for Women's Health, so that practitioners can have open, supportive, and effective conversations with women that do normalize discussing substance use. They support women's change. They personalize the conversation and approaches that women need and to their needs. Encourage them to have the conversation, discuss next steps, and check in. Beyond brief interventions, women may also further need support. Efforts to avoid the harms of intersecting forms of stigma are amongst the most significant factors deterring women from accessing supportive health care and services. But offering holistic, integrated support for women with substance use concerns is an emerging best practice in how to support these women. These programs can be provided through various models, including outreach, multi-service co-location, or a network of community-based services. And using trauma-informed and harm reduction-oriented and women-centered approaches can really help overcome the pervasive stigma and other barriers that some women experience. Interventions that address the social and structural factors that affect women's ability to access services are often the most successful in engaging women. And so on this slide, we have an example of what we've seen in some collaborative models where providers work in multi-service or co-located programs, and shows what clients described as important to their substance use reduction. Other forms of services can also take similar approaches that are really engaging and responsive to women's needs. And so that could look like home visitation, case management, and all of these different models that empower women to make healthy lifestyle changes through holistic, trauma-informed, and harm reduction-oriented care. Certainly, this research has shown that there are so many ways in which we can address the barriers to alcohol abstinence reduction and also support women's agency. And so we really hope that you take that away as we say goodbye for today. Please feel free to reach out if you have any questions. We've included our email here, and thank you so much for listening to us today.
So thinking about what we've just seen from these presentations about brief intervention and support, Dr. Montag really well described the research done over a decade on FASD prevention with an American Indigenous community. And she describes how a randomized control trial of a screening and brief intervention approach really guided them in putting in place a range of important women-centered, culturally congruent, community-based responses, and also inspired them around next steps in research studies. The Project Choices is an evidence-based preconception intervention designed to help women reduce risky drinking and/or use effective contraception. And Dr. Hanson here discusses key adaptations to that intervention that are really possible and in a way that's really helpful to researchers and community advocates in different contexts, working with different groups of women, such as in her case, Indigenous women. And she too points to some additional research avenues to build upon the guidance she describes. And then the systematic review of qualitative studies by researchers in Canada and Australia really looked at the factors influencing alcohol use in pregnancy from the perspective of women, as was captured in qualitative research. And women noticed the influence of relationships, of stigma, of experiences of trauma, of conflicting messages that they receive from practitioners, as well as the lack of access to trusted, non-judgmental, equitable, harm reduction-oriented care and resources. So, this gives us a great idea, as the authors identify, about what how women see the influences on their use and how that can guide our brief intervention approaches. So again, if you're interested in discussing the implications for practice and policy, you're welcome to contact the researchers who presented or those of us at the Canada FASD Research Network.